Bom dia de novo. Welcome. Good morning, everybody. To the persons that have already joined, welcome to the Health Data Forum Global Hybrid Summit 2024. It's really a pleasure to have you all here with us today in this wonderful venue, courtesy of the Câmara Municipal de Cascais, our municipality, the municipality where you are right now today. It's been a strategic partner for our summit this year, and we are very, very pleased to have you all in this wonderful space today with us. So perhaps I'll welcome to the stage now Dr. Gustavo Tato Borges. Is a public health specialist and was having several roles, even as a former regional director of healthcare in the Azores Island.
Thank you.
Good to salute you here. And it's a great an honor to have Gustavo Tato Borges, a person with this knowledge of public health. And it's actually now currently the president of the National Association of Public Health Doctors in Portugal, Public Health Medicine in Portugal. And it's great that he can share this session too with us. Also calling to the stage our moderator, Mariana Canelas Pais, Data Science Director of MTG Research and Development Labs. So a knowledgeable person and very, very expert in the field. As we already witnessed last session and the symposium in the closing session with Professor Shirley Wang. It was a great conversation, Mariana. Congratulations for this. And also Professor Fredrik Nyberg, if you can join us at the stage. You prefer to be here to see the presentation. Oh, that's a very practical sense person. Absolutely. But that's fantastic. Sorry about that. That's no, I was not aware, and it's very sensible, of course, but welcome and thank you so much for being here. I now call in the Zoom so we can see our participants if they show up here. As I give the floor, yes, they are fantastic. I give the floor now to the Mariana is going to be the moderator of the session, and I hope you enjoy it thoroughly. We are relaxed for time because after this there's the Knowledge Cafe, so we will go in continuing until lunchtime. So we are relaxed with time, and I hope you enjoy the session.
Here, and I hope I think this has all the conditions for being a very, very interesting conversation. We will have several panelists who are joining us remotely. Okay, so my proposal would be that we make a short presentation before each presentation, a hybrid presentation. Okay, so I won't bother you with all the CVs of every panelist right now. I would also like to give word now to our chair, Gustavo Tato Borges, who is a public health medical specialist and the president of the Portuguese Public Health Medical Association. He served as an assistant professor in the Integrated Masters of Medicine in Abel Salazar, and also is involved in coordinating several public health initiatives. And I think he will be opening this session on the burden of disease. So I pass my word to you.
Thanks, Mariana. Hi, everyone, back here and at home. And I want to thank for this invitation, Dr. Paulo. It's a pleasure to be here on this very important topic for public health. We understand that real-world data and real-world evaluation can bring a very important input to what are public policies development, what are public health interventions, and getting to know exactly what are the main benefits of each one of these interventions. Because when we train as doctors, we are always focused on our CTs. They are the best kind of data we can get, and it is true. It is one of the, if not the best. But when it applies sometimes to the population, we don't see the results that our CT gave us, because there are a lot of variables that can be changing how it can be implemented or how it can influence people's decisions or health. So getting to know all these backgrounds, all these social determinants, the places where everyone lives, how their culture influence with their habits, and how that reflects in their data and the real world data can be of extreme importance in getting to know the right actions to implement. So public health is always looking for the best evidence, for the best practice to get the most gains we can get in health promotion and prevention of disease. So this is a real important topic. I think there's a lot of potential still to be found because we are not used to use all these data. It can be also a cost-effective way to get real results. And we saw earlier with one of our speakers, Dr. Shirley Wang, that it can be can get the same results with less costs, which is also very interesting for us in getting to know exactly how clinical practice can be influenced by all these little determinants that RCTs may not capture. Can be a very important thing. So I'm very pleased to be here with you. I'm looking forward to all the presentations and in the end having a great conversation with all of you. Thank you very much.
Thank you so much, Gustavo, for setting the stage. I will now pass the word to our first remote panelist, who is Bochen who is a statistician in the Department of Data and Analytics at the World Health Organization in Geneva, Switzerland, and his responsibility is producing WHO's regular estimates for all-cause mortality, causes of death, and burden of disease for the WHO member states. So he's also involved in analyzing health-related data and drafting the WHO's annual flagship reports for monitoring sustainable development goals, including the World Health Statistics. So we will have, I will pass the word to you, Bochen. So please go ahead.
Yeah, thank you, Maria, for the introduction. And good morning, everyone. It's my pleasure to be here and give you a presentation on how WHO use data-driven monitoring to monitor to study the trend of global burden of diseases and to get policy development and implementation. So let me start with a brief introduction of how we do this. The tool we're using to monitor global burden of diseases is some flagship data set we call Global Health Estimates. It's a compilation of WHO's official estimates of mortality and loss of health, disaggregated by country, sex, age, year, and cause. And in this data set, we have a very comprehensive report on the annual health outcomes for over 160 diseases and injuries for WHO member states from the year 2000 onwards. And our latest estimates covers up to the year 2021. And in this exercise, we consolidate and harmonize the best available data from various sources, including the national vital registration data, and also the latest estimates from WHO technical programs, from UN partners, and also from the global burden of diseases and other available scientific studies. We applied a variety of demographic, statistical, and epidemiological methods based on the best science available to derive our estimates. And as I mentioned, those data are disaggregated, and we also provide several related indicators that are key to monitoring population health, including life expectancy and healthy life expectancy, as well as measures for burden of diseases, including the years lived with disability to measure the disability at population level, and also the disability adjusted life years to account for the total burden of diseases by cause and by population. So let me start showing you some of the results we get from this data set. As you can see here, this graph shows the trend for life expectancy and healthy life expectancy at global level, which is a thick gray line you can see, and also at regional level, which are the colored lines, and by sex, So basically, what we observe here is consistent with common sense that the richer the population, the higher the life expectancy and healthy life expectancy, and also female in general have higher life expectancy and healthy life expectancy than men. And the other thing to notice that we've seen steady progress with increasing life expectancy and healthy life expectancy until 2019, before the pandemic, where we see almost 1 year drop in life expectancy and healthy life expectancy between 2019 and 2021 at global level. The other thing we have from this data set is the ranking of the leading cause of death and the DALI. What we can observe, this graph shows the top 10 cause of death and DALI, and the change of that between 2000 and 2021 at global level. We can clearly see an epidemiological transition from these graphs, with communicable diseases accounting for majority of the top 10 causes at 2000, but at 2021, the non-communicable diseases account for the vast majority of the top 10 causes for death and DALI. And this shows the change in top 10 causes of death at a regional level by WHO regions. We can clearly see some inequality here, and the different regions are at different stage of epidemiological transition. For example, we can see the communicable diseases still dominate the top 10 cause of death in the region of Africa throughout 2000 to 2021. But in regions like the European region and the West Pacific region, the non-communicable diseases already dominates the top 10 cause of death. And this is a similar picture for the leading cause of DALI. What we can see is a trend that's similar to the shift for the leading cause of death, as we see in the previous slide. And this slide shows the trends in cause-specific age-standardized mortality rates between 2000 and 2021 for the leading cause of death. What we can observe from this graph is overall we see decline in most of the leading cause of death, especially for communicable diseases, for example, TB, diarrhea, we see a significant decline, also HIV/AIDS. But for non-communicable diseases, for example, cancer and diabetes, we still see a rising trend in mortality in some of the regions. And this graph shows the crude death rate by cause. The crude death rate is a better measurement to see the overall disease burden, which is also affected by the population aging and population growth. So different from the previous slides, we see for many of the non-communicable diseases, we actually see an increase in trends due to population aging and growth. For example, cancer and strokes, we see some regions, and also cancers and diabetes, we see in some regions the increase in crude mortality rates are significant. And this is another way of looking at the disease burden and using the health, the mortality and morbidity data to guide policy development. So this graph shows a decomposition of the change in healthy life expectancy between 2000 to 2019 to capture the trends before the pandemic. So breaking down the change in healthy life expectancy into morbidity and mortality, we see majority of the change of the 5.4 years increase in healthy life expectancy was attributed to mortality, which account for over 90% of the change. And if we look at the figure in depth, we can see by a decomposition by causes and changes. I think the biggest contributor to the change in healthy life expectancy is the declining mortality rates from neonatal conditions, which contributed to over 0.6 years in healthy life expectancy. And we also see contributions from other communicable diseases, such as HIV, for the population aged 30 to 69, and also TB mortality decline also for the same age group, 30 to 69. And on the other hand, we see the contribution from declining NCD mortalities among adult population aged 30 years and over. For example, the ischemic heart diseases contribute to almost 0.3 years in the increase in healthy life expectancy between 2000 and 2019 among the age group 30 plus. And on the other hand, we see the contribution from the changing in morbidity is not as big as the change in mortality. But for some diseases, especially diabetes, contributed to a significant share of the contribution from morbidity. So diabetes alone contributed to, well, 0.1 years decline in the whole, in the change in healthy life expectancy, which is in the opposite direction than all the other causes, which sends an alarming message to the public health community. So this is the end of my presentation. I will stop here. Over to you, Maria. Thank you.
Well, thank you so much, Dr. Bochen, for your very important macro perspective on this burden of disease and how we can leverage real-world data to actually have a macro picture of several conditions. I would now pass the word to our next panelist, who will be Juan Ventura, who is the Research and Patient Engagement Director at Cancer Patients Europe. He will give, of course, a different perspective, more from the patient side. He studied pharmacy and obtained his PhD at University Complutense of Madrid. Ventura, he conducted basic research in international institutions and such as the University of Cambridge and Kew Leuven, and focused in identifying target cells and molecular biomarkers for the diagnosis of therapy of various cancers. He then transitioned as a patient advocacy and participated in over 20 EU research projects, bringing the patient perspective to the forefront of the research initiatives. I will pass the word to Juan Ventura.
Thank you, Maria. First, I would like to apologize because I didn't prepare any slides, but I will try to be clear about our idea over the use of the real-world evidence and how important that is for patients. First of all, I would like to, I'm representing Cancer Patients Europe, just for those that don't know, because we are a very young pan-European cancer patient organization, and we have around 55 members, associations of more than 23 countries in Europe and beyond. And we try to represent the voice from the patients in at the European institutions, but also research projects and everything that can suppose a benefit for the life of the patient. First of all, it's important to put in context. Health in Europe is really heterogeneous, as is at the under the control of the national level. So that creates huge disparities even inside the EU at the time of the providing services for patients and the availability for medicines and other things, and also at the time of having clinical trials available for those patients that are in certain countries. Especially, there is a huge gap between West and Eastern countries in the EU. What it means that creates underrepresented, not only huge populations, but also other groups, even inside the countries. We have underrepresented women, children, but also minorities within the countries. We are trying to work hard. We are inside the European Medicines Agency as a stakeholder group that tries to advise and way to create better and more efficient clinical trials. And that is part of our concern, is to try to reduce disparities. So for us, real world evidence brings hope and a way of creating and giving a more realistic use of the data, considering those other groups that are not represented just for the clinical trials. This is important for patients and it's essential, and patients are really happy to provide their data, especially if one is used for research and it can bring benefits for them. That is something that now we are expecting that can be improved with the new EHDS, the European Health Data Space, that is going to start soon. We have been part of as well of the advisory groups that are trying to improve that regulation. And we hope that that can help to a proper use of the real world data to create a better real world evidence that can be helping patients to have a better treatments and better quality of life. And talking about quality of life, that is something that the patients can bring as a real goal for the use of this real world data. That is, and not only collecting the data from the clinical perspective, physical and state or the type of side effects that may happen to the patient, but also the mental health, the social repercussions that they can have with the treatments, how they accept the therapies that they went through in the long term. We have to think that sometimes from the clinical point of view, we forget that what we consider just the survival thing in terms of one or more or less months of the survival for the patient may not be that important if they have a miserable quality of life. Sometimes they go through a very tough treatments that suppose a huge consequences with strong side effects that affect all the parts of their lives, from their family life to sexual life or the social interaction. And that for them is when you have to live in those conditions, really something that may not be accepting the type of path they've gone through the treatment. So that is something that we should also include at the time of collecting this type of real world data, and should be considered an essential part. Now, in terms of the European approaches to try to introduce real-world evidence into the spectrum of the consideration of the analysis of the data that can help to better understand the needs and the gaps they're not getting from the clinical trials. We are also trying to collaborate with the European Medicines Agency in this new network that they established 2 years ago. It's called Darwin EU, and even in this case, we see that the participant countries that are right now, I think if I remember correctly, around 13 countries participating, is again, we see the same gap between the West countries that are mostly all participating and just a few countries from the Eastern Europe. So all these disparities, we are fighting hard to try to reduce, because we think that the data from all countries will improve the quality of the final clinical solutions that we can provide, but also to give them a specific voice to those that are not represented in that type of data. So for us, it's essential that all those countries, some of them, they don't even have cancer registries. So these things, hopefully with the new EHDS, the European Health Data Space, can change, improve the collection of data as well from the biobanks and so on. And essentially, there are anything that can be done and can improve the quality of life for cancer patients will be supported for us, and try to implement a better collection and a proper analysis will be essential for that, but always considering the point of view of the patients. That has to be part of the goals at the time of what type of data to collect and how to interpret that data. Thank you.
Thank you very much. I don't know if you heard, there was clapping in the room, just so that we have some interaction here, since it's a hybrid panel. If you don't mind, I will ask a small question that is what usually comes up when we have more of a patient perspective in this kind of setting, which is, what's your sensibility regarding the balance between privacy and getting those insights that actually matter for patients? In your perspective, how do you feel this balance is being met? How do you feel the patients feel about their data being used? And what do you think could be improved in making sure that these kind of concerns are met?
Well, there's been a huge conversations about this thing, of course, during the development and the advisory groups for the EHDS, because there is an essential part, privacy and what it can data provide to the patients. Patients usually, in the majority, they are happy to provide their data for secondary use, if it's research, of course. That is almost a general agreement about that. There is no problem for them to provide the data, because they expect that research can really improve their and give them benefits out of that. What we have to do with that is, of course, offering the security, because that can give them trust about the system, that the data is not going to be used in other ways, that is something important, and then they will be happy to provide data, because in the end, research without that is going to be limited, and they want to support research as much as possible. That is why we are trying to get patients engaged into the European research projects that we participate. They are improving very much the way that these projects develop. In the beginning, there was a lot of the concerns from the clinical perspective about why patients should be participating in these projects. Now there is no concern. In all those projects where the patients are part of, and they can review, and they can give their experience and what they have, their expectations they have, those projects are developed better, and they go to better goals and sustainable outcomes. So essentially, the patients are interested in research, and they are happy to provide that. We just need to give them the trust that that data is not going to be used for other purposes than what they want.
Yeah, I definitely understand. And I would also like to share that we have discussed this side, and I think there are several approaches that may be the best compromise between having these two worlds and these two needs, both privacy and getting the outcomes met. Thank you so much for your participation. I would like to introduce our next panelist, who will be Professor Fredrik Nyberg, who is the professor of Registry Epidemiology at the University of Gothenburg, School of Public Health and Community Medicine. Main research focuses on utilizing registry data to study epidemiological trends and health outcomes, contributing to evidence-based healthcare practices. Professor Nyberg has published extensively on the use of real-world data in understanding the disease burden and the effectiveness of healthcare interventions. The floor is yours. Please go ahead. Thank you very much.
Thank you. All right, so thank you to the organizers for inviting me here, and I would like to share with you a little bit some experiences I've had in using register data on disease burden for public health purposes as a researcher in academia. I'm a professor of Registry Epidemiology at Gothenburg University since early 2020, and before that, I'm a physician by training, and I did research on more environmental epidemiology and smoking and passive smoking early on, and then spent 20 years in pharmaceutical industry supporting projects with epidemiology, coming back to academia in 2020. So I would like to share with you today 3 examples of work I've been involved in the last few years. And doing that, I will touch on data sources a little bit, and also how you sort of work across data sources with things like linkage, linking different data for the same patient, pooling to increase sample size, perhaps collaborating to increase sample size even more, and also developments in common data models and collaborative federated analyses. So as you remember, in 2020, something happened when I had just started at the university. I was getting ready to do other types of research, and then Corona came along, and soon everybody knew what epidemiology was, and that was nice. But of course, I asked myself as a researcher and as a citizen, what can I do? What can I do here? And I ended up doing 2 main things. One of the things was that I was already, since my pharmaceutical days, involved a little bit with quite a bit with the Odyssey network, which we have heard mentioned and which we will hear more about in other presentations, I think, during this conference. And they had been planning a European meeting in London, which was, of course, cancelled in March. And instead, they held a so-called study-a-thon a 3-day meeting on Teams where up to about 200 researchers across the world worked 24 hours per day for 3 days to sort of define the questions, check the literature, design the studies, do the code, produce the results, interpret the results, and write the draft manuscript, all in 3 days. A really interesting experience, really interesting experience. And then we ended up actually at the end of those 3 days with 2 draft manuscripts, and during the ensuing year, we continued to collaborate on a sort of weekly basis, virtually, and especially in this large project, which was a descriptive project, Charybdis, we described characteristics of the COVID patients and to some extent compared them with influenza patients. You remember there was this discussion about, is this just a new influenza or what differentiates it? And we produced papers that were quickly produced on medRxiv and then in publication in journals, and that contributed to the further research and the management of COVID patients at the height of the pandemic. The speed of this collaboration, of course, was predicated on the fact that there were databases, particularly American ones, but also there was a Spanish one pretty early on and some Asian ones that were involved that had data in this OMOP common data model that the Odyssey maintains, which is basically a model that decides how your data should look, which tables should you have, what names should your variables have, what values should they have, how should they be connected with each other, there are vocabularies that translate your codes into to standard coding systems within the OMOP model, so that once you have that, you can write code quickly, which everybody who has the data in this model can run fairly quickly on their data, and then you can pull the results with meta-analysis. The other initiative I ended up doing was I asked myself, what do I do as a new professor of registry epidemiology in Sweden? Well, a large register study, of course. And so I designed the Sci-Fi Pearl project, the Swedish COVID-19 investigation for future insights, a population epidemiology approach using register linkage. Just a couple of words about the Swedish system then. We have a lot, as you know, we have a lot of good national registers that sort of cover the patient experience or the individual experience from early life and to late life with causes of death and over the whole life course. And in the life course, you have these health data like cancer data, inpatient, outpatient data, prescribed drugs. You also have clinical quality registers and specific disease registers, which are not always national, but often national. And then you have population information and family linkage information that you also can access. And to this, you can further add socio-demographic and socio-economic information that, in particular, Statistics Sweden holds. So I designed this study very quickly in April. We got ethics in May already, and even with the priorities to get data, it took us almost half a year to get the data together. So in October, we had the data for this Swedish database together. So I think that's a problem for a future pandemic, that even with priorities, it just takes a little bit too long to make decisions for all the different data holders. What we ended up doing was collecting a pretty large amount of data on the Swedish population. We got data on health from the National Board of Health and Welfare on the left. The Public Health Agency of Sweden contributed with COVID-19 test data and later on vaccination data. We had socio-demographic and socio-economic data from Statistics Sweden. We had a range of national quality registers focusing on intensive and acute care, but also cardiopulmonary disease registers in particular, because those were, as you remember, fairly early on seen as the key risk factors in COVID. We do not currently have a national register for primary care data in Sweden. It's divided in the 21 regions in different formats. But we did want to have some primary care data, so we ended up including primary care data from electronic health records in 2 regions, the 2 largest regions in Sweden. So that covers about 40% of the population. And with that, we had a large project with a database where we could identify COVID-19 cases and different outcomes, different population groups, and perform various types of analysis that we had ethics to do. And here are some examples of the output that were then used to inform healthcare and clinical care and public health in Sweden and elsewhere. And most of these have now been published. We have continued to work with this database and still are doing some work, especially on the vaccine research and post-COVID part on the right. But we have done things on the effects of medicines on COVID risk. We've looked at the pandemic, how it affects the use of healthcare and medicine use. We've looked at socio-demographic determinants of COVID outcomes and COVID risk. We've looked at the risk of COVID in different patient groups and other special groups, and of course, the risk factors for COVID. The third thing I want to just share with you is our current work then, and that brings me to EDEN, which is a large project, an IMI project, Innovative Medicines Initiative, so financed by EU and pharmaceutical industry jointly, with a number of different objectives. And the key one for us here was that one of the key objectives was to try to get many databases of different types in Europe to convert their data to the OMOP Common Data Model. And we were happy to be engaged with them and receive one of their grants to convert our data to the OMOP Common Data Model. You already heard mention the Darwin EU project. So one entity that has shown an interest for the OMOP Common Data Model, partly because of the speed with which you can do some things, is, of course, the EMA, the European Medicines Agency. And this illustration just shows you a schematic illustration of how this Darwin EU project works, that the regulators would need to make a decision, and they would say that we need this evidence, that there is a Darwin EU Center at the Erasmus University in Rotterdam, coordinating center. They would then manage study governance and contact the data partners, of which we then want to be one. And the data partners would be involved scientifically and with the data, perform the studies, feed them back. They would be collated into a report for the EMA, and there would also be scientific publications out of that. So this is what we're working with now. We have our data. We've called this new project, which we now have ethics to do also in Sweden. We've called it High Speed, Health Impact Swedish Population Evidence Enabling Data Linkage Study. And basically, we've now completed the leftmost part, sort of setting up the database, and we have the analytics in place. We are talking to the EMA and the Swedish regulator to become a member of the Darwin EU network. We have OMOP converted large parts of what we had in the previous Sci-Fi Pearl study, and we will now move on to doing pharmacoepidemiologic studies, developing methods and tools, and conduct studies to a large extent in collaboration with Darwin EU, but also our own studies for the benefit of patients, society, and regulators. So that's what we're moving into now. Oops. And I think that's where I will leave you. My conclusions and what I would open up for discussion is that, you know, we are collecting these really large amounts of valuable data in healthcare, and some of them are moved into specific registers also, but they're also there primarily in healthcare. And I think these data have to be used for the benefit of patients and society. They can't just lie there and not be used. And if we're going to make good decisions, we really need good evidence. And sometimes that evidence needs to be fast. Sometimes it doesn't need to be fast, but we need to have processes in place to be able to do all of those things. It has a high value. I've shown you some examples more oriented towards healthcare and public authorities, but there are also examples from my time at industry, and industry is increasingly using observational data as a complement to their RCTs, and that's really important also. There are lots of exciting developments now in this space. I mean, there is the big data, all of the data that we're seeing, and how are we pulling that together? The common data models and the federated analysis strategies, where you can actually analyze the data without having to send all the data around, is really a good development, I think. Increasing collaboration across countries, not the least in Europe. And I think the European health data space was already mentioned, and I'm not going to go into any details, but I think that's also, for better or for worse, hopefully for better, going to change the way we are able to access data and collaborate together. And with that, I would like to just, this is my core group, and I would like to thank them, and also all my wider project team and all the individuals who have been involved in these studies, in this research. So thank you with that.
Thank you so much, Professor Fredrik. I think we set the conditions for a very interesting discussion. After our last panelist, we still have an hybrid, we still have a remote panelist, which will be presenting next. So now I will pass to Dr. Christina. I'm afraid, but I think it's Kyriakopoulou. I hope I did not pronounce that wrongly. Who is a senior scientific officer in the health research programs at the Directorate General for Research and Innovation of the European Commission. She oversees health research initiatives aimed at addressing public health challenges in Europe. Her work involves coordinating research projects, fostering collaboration among European research entities, and ensuring that research outcomes inform policy and practice to improve public health across the EU. So hopefully we'll have yet another perspective in this session. Please, the floor is yours.
Thank you very, very much. Do you hear me? Yes?
Yes.
I just want to share my presentation. It's a pleasure to be here. I would like to project now my presentation in slide mode. Just let me know if you see the presentation.
It's not, yeah.
Now, do you see?
You need to start the slideshow, I think.
Yes, I have.
Okay.
No.
We don't see.
It's not moving. Okay. Again, sorry. But do you see my presentation at all?
I think you may be sharing the wrong window.
Okay. Stop sharing.
Okay.
Sorry for
the
this.
Presentation.
I just do it another time because we tested before and it was working. So now I'm doing it again.
Okay. It's okay.
Do you see now?
Yeah. Okay.
Presentation mode. Okay.
It's not in presentation mode, but I think, can you switch the slides? Just
I switch
once?
Now? Now?
You know, like, because
does it switch now?
No, it's not moving.
Yeah, but I mean, you can share from the PowerPoint itself without slideshow, if you don't mind.
Okay, just a moment. Just a moment. I'm sorry. What do you think now? Did I manage to do something?
We see PowerPoint without being in presentation mode, but if you like, we can see it like that. It's quite legible.
That's okay.
But
now?
you need to change the slides in the editing
Yes.
part itself.
Do you
Yeah.
see now?
Yeah. Could you
It's
change the
changing?
slide?
It's changing?
Yes.
No, it's
Yeah.
changing.
Yeah.
now.
Yeah.
Okay.
It is.
Okay. Thank you very much. Pleasure to be here. Sorry. I think I was planning to have a lot of several slides to describe to you the European collaborative health research landscape in real world data. But I want to mention, first of all, who we are. I mean, in our unit, my head of unit, Carmen La Plaza, she was invited, so I have the pleasure to represent her. So we are working at the Health Directorate of Research and Innovation, at the unit Health Innovations and Ecosystems, and we are developing the Health Cluster Work Program of Health Collaborative Research, which is the main goal is to improve the health and well-being of the people with delivering effective health care, but also by generating new knowledge, developing innovative solutions. And of course, the data-driven innovations is very central in the digital solutions, but without our ultimate goal for tackling the burden of diseases and delivering sustainable health care. Do you see, do you have, can I continue?
Yes, please go ahead.
Yes. So in our unit, as I mentioned, in Director Research and Innovation, we oversee in co-creation with other EC services, the research policies and development in collaborative research under 6 destinations. Several of you know that, but I just want to say we are aiming to support research and innovation actions and activities, coordination, strategic actions, partnerships, public-private partnerships. I heard the innovative medicines initiatives examples to deliver short, medium, long-term impact in improving the impact of the environment on health, prevention, in ensuring sustainable and high quality healthcare, in unlocking the potential of technologies and digital solutions for health, for a healthy society, and also in boosting and sustaining a global competitive industry. Here, I want to say, the program that I'm referring to, has the motto multidisciplinary, multinational, multi-stakeholder collaboration. The European model on health research, which we have been trying in health research to apply for decades now, basically connecting people, ideas, disciplines, countries, data, technologies, driven by end clinical needs, driven by the end users' needs, the patients, the society, to deliver and to create wisdom, to connect all these dots together, to deliver tangible health outcomes. I mean, this is the ultimate goal. And what I wanted to mention here, still after so many years, at least at the European level, collaborating together with different disciplines across countries with the data-driven innovations to tackle clinical needs, we are still, I think, in the phase trying to jump from analyzing data to provide new information, to create new knowledge, and to be able to understand the pragmatic situation in a real life situation. So that's for me is a big challenge. And what I have heard today, I think we are aligning in the thinking. Why are we using data? Why are you using big technologies? Why are we using artificial intelligence? Why are we using try to harmonize, to make more interoperable and the data in order to deliver benefits to the citizens? So, and here I just want to take you back in some before even we were start talking, at least 10 years back, discussing about the European health data space. The European Commission, via different framework programs back in 2010 already. We started investing in collaborative and multidisciplinary approaches to support data-driven innovation, but in order to address public health policies, in order to have more basic research, combining the data to understand the disease heterogeneity, for example, data-driven approaches, modeling, etc., to deliver more novel approaches for patient stratifications, because we know how different is the disease course or the heterogeneity of disease, and how do we treat patients and how do we diagnose patients with this heterogeneity. We have invested a lot in big data for early detection of infectious diseases, as a bunch of important projects back from 2000 to 2018. But of course, when COVID started, we, as all the world, as all the funders in the world, we tried to boost research, and we have set up very interesting observational cohort studies in order to be able to understand the disease heterogeneity, the progression of the disease, the severity, and also the different complications, comorbidities, etc. An important strategic orientation of the health research since 2011 have been the great support on the development of personalized medicine, molecular medicines with data approaches, for example, strengthening research on genomics, multiomics, novel biomarkers, artificial intelligence algorithms, and of course, a lot of projects supporting the COVID challenge that we all faced. And here, what I want to say, like an important milestone in the European health collaborative research and all EU health research programs, has been the introduction of open access policies since 2016 and the open research data. So as a result of that, in the health research, we started implementing pilots on open health data and according to the FAIR principles. So all the data-driven or intensive projects, now it is kind of a requirement to apply the FAIR principles in different levels of maturity, depending on the question or the clinical challenge that the projects try to address. But the FAIR principles, a lot of such projects, consortia, have been contributing in making data fair, findable, accessible, interoperable, reusable, and machine readable in order to allow better use by new information technologies. So that was a really boost at the research level before even we start talking about the European health data space. Has been already created a maturity in the health research data ecosystem. Of course, interoperability, fragmentation of data in different repositories still exists. And now I will just switch to some examples of real-world data in EU collaborative research. We have seen several types of projects try either to optimize different types of data that I say, epidemiological cohort studies, registries, medical electronic health records, pragmatic clinical trials in the real world setting, and slowly mobile apps and digital sensors data are coming into the pictures. And what I try to put here, what we have seen delivering these projects, that they were using real world data. And for example, it is very important to understand the new taxonomy of disease, to identify predictive biomarkers of disease progression, to facilitate clinical research, for example, natural history of disease or observational clinical trials, or now the trend that we see, and we have some projects supporting that, is how could we use real world data, historical data from registries, from cohorts, to augment or to optimize clinical trial designs to have more effectiveness. Or we have seen clinical research data for in silico trials. Of course, a lot of investment on infrastructures, it's needed. We have been supporting slowly, gradually this with European collaboration to connect, link, integrate real-world data for health research, and also real-world data in medical technologies. And artificial intelligence is becoming very important in order to validate artificial intelligence algorithms which correspond to the reality and to the pragmatic situation and the needs of the patients. And here I don't want to go to registries, how important it is as a real world data source. And we have several examples how to supporting registries for different in different stages of the innovation path, from translational research, clinical research, and post-marketing evaluation in real-world settings, optimization of the effectiveness. And here I just telegraphically say some important clusters of projects, and I know several of these projects are represented in the forum, in the forum, Health Data Forum. Like IDAVA, we have a very nice cluster of projects which they are trying to use real-world data or synthetic data to support regulatory decisions making and health technology assessments. And these projects, we are trying to communicate from our side to our colleagues in EMA and to the side and to the broader stakeholders the results of these projects and what is the value on bringing real world data in the post and pre-authorization and post-authorization of medicines development. I will not say how important projects have been in the Innovative Health Initiative. We heard about Eden, which is really a very successful project from a public-private collaboration. I will not say how important and fantastic work our colleagues in EMA are doing on the strategy that they are developing to optimize regulatory needs and medicines development using real-world data. A fantastic work has been produced, paper on describing how important is the real-world data quality. And here I just want to say that what we have seen in this, and I will finish here in this project with this presentation, how important it has been, this data-driven approach in the collaboration at the European level to be driven by the clinical needs. So clinicians working together with data scientists, having the input of the patients, because very complex diseases, we see patient-reported outcomes coming into the picture of real-world data. How important has it been to have a pragmatic view and be driven in your data road path by the clinical need in order to deliver and improve the life of citizens, an optimal healthcare solution. So and the multidisciplinary approach is very critical. And I will stop here. Thank you very much.
Thank you so much, Christina. I don't know if you listened to the claps, but I transmit that there was claps here in the audience. Thank you so much for your perspective. I ask of you if Professor Fredrik could join us. We will have a little bit of a closing discussion. I think we will be kind of on schedule. If we request some extra 5 minutes, please don't blame, because we think we can make good use of us being here and wrapping up some things that I think are very interesting that we would like to go into further detail. And thank you so much for sharing your perspective and touching on the data standardization part. And you know that I am very fond of this subject, but I will touch in a bit of a different thing that is kind of a limitation of using the OMOP data model, which is it is patient-centric, which is good, but it is very healthcare-centric also. And I would like to know your perspective on having added to the information that we have from healthcare sources, other sources that may have very important information that impacts on health outcomes, such as environmental and other secondary social economic informations that may be concerning a whole region. And how can we deal with all these other data sources that are not so healthcare centric? And if you have a perspective on this.
Yeah, that's a really difficult question, and I've noticed the same problem in. I think it is a problem with any specification you choose for your data will be optimal for some users, but not optimal for other users. Having said that, I do applaud. I think the OMOP common data model has come a long way and has a potential to be at least one of the standards. And I think that adding some non-health data to that model would be useful. But I'm not sure that all types of data will gain so much from there. So I think there needs to be some assessment of how much use you have of that, because it's so patient-centric. And there are other problems about it too. There are underlying assumptions, like there is an assumption that you have an observation period, which is a sort of an assumption that all the data that you have connected in your OMOP database have the same observation period, which it doesn't necessarily. And so there are all these assumptions that you need to be aware of. And I think if you try to press too many things in, then it's not going to work. So I think there will be a need for other data standards also in parallel with OMOP.
Since we are touching these touchy subjects, I should also mention the problem with the semantic layer and the translation of concepts, and how we have to deal with this, particularly when we have federated collaboration studies, and how these kind of different translations that are met may impact. And if you have some insights and even, I don't know, some examples where you have to deal with different kinds of ways of translating slightly the same but slightly different concepts, and how we can go about this in the future.
I'm not sure I can provide more. You probably know more about. We're fairly new to it, but it's clearly one of the things I have noticed, that it sounds really good to say that there is a translation in place from one system to another, but that translation may be interpreted if you have almost similar data, as you say. Different databases may implement a slightly different translation into standard concepts. So you end up in different standard concepts anyway, even though, at least for some applications, you would think that you have the same data. And so I think one of the problems I see with the OMOP common data model is that the translation process, once it is done, is not so transparent. So I think that more tools to show and share your translations with other users of the OMOP common data model, so we can understand each other's translations easier than we can today. I think that would be a useful thing.
So better documentation could be of this kind of, yes. So, and this is kind of, as you can tell, a little bit database centric, this conversation, but I will focus on an additional topic that I feel is important. So you deal mostly with registry data. How do you feel that the kind of source that we are dealing with, be it claims, registry, or like EHR from source information systems, and some other like secondary use of an RCT database, and how this kind of, where this comes from and how data is generated can also impact, and how we can mitigate some of these problems, methodological or is it not possible? How can we go about this? What's your insight in this?
Yeah, I think what you're saying emphasizes that we're nowhere close to eliminating the researcher or the data owner or the data knowledgeable person from this equation. So it's not as if you can translate it all to OMOP and then just throw it into one big pile and anybody can come in there if they know OMOP and use the data. Because a diabetes diagnosis that comes from a claims database could have biases related to the way payments are being made. A diabetes diagnosis that comes from primary care has different types of qualities. A diabetes diagnosis that comes from a hospitalization has a different quality and it could have different qualities in different countries. I don't know if it's possible to code some of those differences. So you might imagine that at least for some variables, you could have associated quality variables that sort of say something about this is a diabetes diagnosis from a claims type of database or from this type of data or from this type of data. That would be helpful perhaps, but I think at the end of the day, you are still stuck with the knowledge that humans have of the data that who are close to the actual collection of those data.
So we need meta information that gives us the context, but we probably will be stuck with most of these being in the brains of who knows for some time. Since we have our panel online, I will possibly give a little bit of a broad question on a cross subject, which is data quality. What's your perspective on this from the more macro perspective, from more the patient perspective, from more of the project-oriented perspective? What some pains that you have felt in this, and some insights or specifics from each of your perspectives. Maybe we can start with Dr. Bochen, if you don't mind.
Yeah, sure. Thanks, Maria. But speaking of data quality, I think it's been a challenge in our work, in our daily work as well, because our work rely heavily on data provided by countries, especially the vital registration data, and to come up with comparable estimates across countries, we actually need all the countries submit data to a sufficient availability and quality. But unfortunately, that's not possible as we stand now. We are providing estimates for 190 plus WHO member states, but only about 120 countries regularly submit vital registration data to WHO. And out of those 120 countries, only about 80 countries provide data that are meeting our data inclusion criteria, which require the data to be, the underreporting of number of deaths to be below 20%, and the AOD fund cause of deaths also to be below 20%. So only about 70 some countries could achieve that criteria. So for the rest countries, we actually have to do a lot of modeling, which we hope with the improvement in the data quality and availability globally, we can reduce the work of modeling, just rely more on the data submitted by countries. And also, there's an inequality of data quality across countries. The better resourced countries usually have better data, and countries with poor resource setting have a lot of problems in vital registration data. Many of them don't even have, many of the countries, especially in the Africa region, they don't even have functioning vital registration data system. and the survey, the population level survey, are very sparse. So that really create a big challenge in our work. So there's a lot of uncertainty around our estimates for those countries without the good functioning health data system. And without that functioning health data system, we really don't have the same level of confidence in informing policy development in those countries. So going forward, I think strengthening health data systems across countries and globally is still a main objective of our work at WHO. Thank you.
Yeah. Thank you. Yes, that's insightful. So I will just appeal for the conciseness but I would very much like to hear your opinion, Juan Ventura, if you don't mind, Professor Juan Ventura.
Yeah. Well, from that the patient's perspective, is again what is important and what is the problem for the quality of the data is the lack of harmonization. Every country have their own protocols. Sometimes even inside the country there are different, and the way that for instance the patient-reported outcomes are collected are very different. So how can you put it all together? That is essential to have something that's standardized that can be used and agreed with all the countries that can participate together. Otherwise, the data is difficult to have a good value for the patient.
Yeah, definitely. Thank you. And now, Dr. Christina, if you don't mind.
Yes, data quality. I mean, data quality has the technological parameters, meaning standardization, interoperability. This is very important for the big data resolution, evolution, and also the AI, more validation of AI to have really input, to have the big data analysis. But I want to put from the health research perspective how important is the quality of the data at source, how you create the data, how they are produced, and for what purpose, and for which clinical question are produced to solve. So it is important when you ask what I want to answer with the data, then you go to find the best possible quality of data in order to do your artificial intelligence analysis or more big data analytics. But it's really important that fit for purpose. So that I think it's very essential at the core of the quality of the data.
Okay, I have a very brief comment on this also. Yeah, two very brief comments on that, and building on what was just said here. I would very much like to see data holders partnering more with researchers, because quality, for the primary purpose that they are collecting the data, they may be concerned with that, but that may not be the same thing as quality for researchers. And the second point is that even for researchers, there is no such thing as quality or not quality. A very simple example is that for some types of research studies, you need a measure with a high sensitivity, whereas for the others, you might need a measure with a high specificity. And, so if you have one with a high sensitivity, that's high quality for that purpose, but it's not necessarily high quality for the other purpose. So again, fit for purpose, not just because it has high quality, but because it has the right high quality.
Thank you so much for all 4 presentations. It's been great here. I'm assigned with trying to get the grip of what was being said around here, and I've learned a lot. And what we have seen, that there is a good amount of data out there. There's the need to make sure that we are talking the same language and that we can apply that data that has been collected for one purpose, for another, or if we can fit them in the right way for the purpose that we are aiming for. And that data should be used for the people and for the benefit of the citizens in order to provide better healthcare and better interventions to promote their health. There should be some kind of, let me pull the topic to my field, public health information system that could gather all this information and that could link between healthcare providers, researchers, political deciders, that we can all see the benefits and the important effect that real world data can have in every one of our aspects. So I think there's a great possibility for public health actions, for innovating in this area, listening to patients, which is also very important, but linking healthcare, research, patients in all their needs and what we are all aiming for. So real-world data is a very important field. We have to invest in it and work together in order to see effectively where there are more gains to be held. So thank you very much for everyone. It's been a pleasure and hope you have enjoyed also.